So my name is Zachary Scott. Welcome to the Harm Reduction in Community Mental Health Settings webinar. I am the manager of outpatient substance use services at Jefferson Center. I have my LPC, which is licensed practicing counselor, LAC, which is licensed addiction counselor, and NCC, which is nationally certified counselor. This webinar and this training has been created in conjunction with the Substance Use and Mental Health Services Administration, also known as SAMHSA, their harm reduction framework that recently came out this past year. I will be providing the links to the full framework so that folks can take a look later and hopefully follow up on questions or ideas that they might have. First, a question to those viewing this. So what brings you here? As we're going through the training today and talking about harm reduction, I want people to keep in the back of their minds, what brings you here? Why are you interested in harm reduction? What do you hope to gain from this training? What information are you looking for? And what further exploration can you do after we wrap up today? I also want folks to think how these principles, these interventions, this framework, this philosophy of harm reduction can help you in your role in life. And it really doesn't matter whether you are in a clinical role, whether you're talking with someone from your family, or even when you're just interacting with other people at work or socially. These ideas, as we'll see, are pretty universal in the way that they help folks to interact and connect and provide care and insight in a compassionate way. So keep those thoughts through your head as we move forward. And these are going to be some of the ideas that we're going to be looking to build upon with what we're talking about today. Some of the overall goals for what I'm trying to bring to this webinar and this training. We're trying to establish a community for harm reduction at Jefferson Center and in our community, in the Jefferson Center communities. We're trying to create synergy for this movement. We're trying to increase the amount of people who have education and who are armed with correct information to try to help implement harm reduction interventions, not only here at Jefferson Center, but elsewhere in the community. We're trying to create a network, right? So this is important within Jefferson Center, but like I said, it's also really important for individuals and healthcare providers throughout the county and elsewhere in the Denver Metro. What we're trying to do is change our approach on substance use disorder. And one of the ways that we're doing that is through these harm reduction interventions, creating a network of advocates, including professionals and non-professionals, is going to be a really important way to do that. We're also going to talk and really establish a basic understanding of the harm reduction core pillars and core practice. Now, when I say core pillars and core practice, as we'll see later, these are defined through SAMHSA, through their recent framework introduction. We're going to talk about what does harm reduction mean. We know that in today's climate, we see the phrase harm reduction thrown around a lot in a lot of different contexts, in a lot of different areas. We want to establish a definition today that applies to harm reduction in community mental health that can help not only clinicians, but also people who support these ideas in our community. I want there to be some insight and some reflection on what skills and ideas and questions can I leave here today with for my role, be it a professional role or a role in society. What can I take from today's information to further help the people that we're trying to connect with, right? The most vulnerable in our society that are struggling with addiction. There's a lot of different thoughts on harm reduction that we'll touch on today. We're going to try to dial down a definition, but also remember too that in a broad idea like this that involves a lot of interventions and a lot of different healthcare platforms, there's going to be a difference in opinion, and that's okay. We welcome that. And having this conversation and having this insight and information is going to be the first step to helping our community. All right, so let's establish a definition. What does harm reduction in community mental health mean? A practical and transformative approach that incorporates community-driven public health strategies, including prevention, risk reduction, and health promotion, to empower PUD, that stands for people who use drugs, and their families with the choice to live healthy, self-directed, and purpose-filled lives. Harm reduction centers the lived and living experience of people who use drugs, especially those in underserved communities, in these strategies and the practices that flow from them. Now, that's the definition from SAMHSA, and it's a definition that works really well into what we're doing here at the center. I want to highlight a couple key elements in this definition that I think are really going to lead in our discussion today. Transformative. So the big picture that I'd like people to think about when looking at harm reduction is we have a big history of failure in this country at many different levels in treating substance use disorder. This goes back to the drug wars, the current drug war and the drug war of the 60s, 70s, 80s, along with underserved communities, minorities, individuals who are vulnerable and get treated differently, to be frank. Transformative means we are really looking to transform and change the way that addiction and substance use is treated, especially at the community mental health level. Another important element here, prevention, risk reduction, health promotion. So we'll talk a little bit more about these three as we get into the pillars. But really the prevention, so we're trying to prevent people from getting into a situation where they're using in the first place. We're trying to reduce the risk of those who are actively using. And we're trying to promote the general health of people who use drugs, whether or not they're currently sober. You'll see that phrase PUD or PWUD, people who use drugs. This is an effort to destigmatize, right? We'll talk a little bit about stigma later too, and the negative effect it's had on the drug using community and individuals who use drugs in this country. We want to get away from phrases like addict, active addict, junkie, obviously things like that. We're moving away from that into language that's respectful and language that allows some autonomy and some self-directedness from the people that we're trying to serve. And that phrase self-directed, also super important. This is a journey that we are not necessarily acting as the primary guide. We're acting as a companion. We are trying to help individuals make choices that positively affect their lives. Whether or not that includes full abstinence is going to be something that they're going to take control of. Harm reduction is a peer-led program. We'll see that in the definition here. Centers the lived and living experience of people who use drugs. So how do we take that experience of not only people who are in recovery, but this is the kind of more radical way of looking at this. We're trying to connect with people who are currently using, right? People who are out on the streets and really experiencing the scourge of addiction firsthand and getting insight from them on how we can help direct them towards recovery with harm reduction interventions. I'll also touch certainly on the concept of underserved communities and equity. The drug war and the pipeline to prison for a lot of drug users has disproportionately affected minorities. We know this not only from firsthand accounts, but from the numbers. We acknowledge that in our harm reduction approach and strategy, while at the same time trying to, if we can't fix the past, at least offer a way forward for underserved communities and people who might have previously been discriminated against. That's an important part of the harm reduction approach, is acknowledging that, and using that experience as a guide to move forward. A couple quick milestones in terms of harm reduction history, so that we can get an idea of where this movement and where this idea is coming from. Obviously, this is not an exhaustive list. These are just some big events that have happened in the history of harm reduction, the history of substance use treatment disorder in this country. As far as the official date of the start of the drug war, this can really depend on a lot of things. You know, you can look back to Reconstruction South to see the initial forays of trying to use drugs and those who use drugs as a way to pull people down in society. For the purposes of what we're doing today, we're going to look at 1971, when President Nixon established the onset of the war on drugs near the conclusion of the Vietnam War and began a very punitive policy to punish drug users. When I say punitive, I mean a policy which is just that, right? It's based on punishment. It's based on, hey, if you do this, we are going to punish you either through jail, financial means. A strictly punitive approach doesn't focus on recovery. It doesn't focus on resources. It doesn't focus on keeping that person safe. It basically takes a moralistic look at the disease of addiction, right? We're going to punish you. We're going to send you away so that we can try to change this behavior through a punitive approach. Another really important and vital piece of this conversation is the HIV crisis of the 80s. When we look to the communities and the onset of harm reduction programs that have come up in the country, a lot of these first started being developed during the HIV crisis, right, where the federal response was not there. We weren't getting clean needle distribution. We weren't getting education. We weren't getting informed providers. None of this stuff was happening in the early to mid 80s as the AIDS crisis was happening. Because of that dearth of involvement from federal sources and state sources and things like that, there became a kind of grassroots effort to start doing some of this stuff, distributing needles, giving that education, starting social groups, peer groups. And again, that idea of a peer-run program, people who have gone through this, people who are going through this being the essential part of the recipe for success. So as the CDC discovered that IV drug use linked to HIV in the 80s, we see this intertwining nature of the two topics that gets pulled into the political life, the social life, the prejudices of that time, especially when we look in the response of the federal government. As the AIDS crisis deepened and got worse, we saw that willful neglect, right, from federal powers to really address it in a way that was substantive. And we really saw the development of community resources for harm reduction, especially out of the West Coast, out of San Francisco. So we saw in 1992 the first official, and I say official because there were non-official elements before this, but the first official harm reduction working group that started in 1992 in San Francisco to create a united definition of harm reduction and to start connecting providers throughout the country. Also super important. We also saw in the mid-90s the advent of naloxone distribution, right? So this is a drug, when used appropriately for a person that's experiencing an overdose, that can be life-saving. We saw distribution of that drug to people throughout society who could jump in, even if they're not a trained professional, to provide Narcan, as it's also known as, to people who are experiencing an overdose and save their lives. In 2019, we saw more than 700,000 doses of naloxone or Narcan were distributed. Finally, and you'll see and I say finally because you'll see the huge gap here from the onset of the war on drugs in the early 70s to finally getting an official policy on harm reduction, finally having SAMHSA take harm reduction and establish these pillars and take all of this knowledge and work that's been done at a more grassroots level in the last 50 years and bring it into official federal policy, which is what we saw in 2021. First ever harm reduction framework from a federal agency and a official stance from the federal government on what harm reduction is, why it's important, and why it can help lead to recovery, which we'll talk about as well. So again, just a initial signpost here of important dates, but it's important to get an idea in our heads as we look at where we want to move forward with harm reduction, like where it's been, and the various challenges that we've had throughout the years to get some of these life-saving interventions and policies into the hands of people that can really do good. So an important element, as we've discussed, especially in the last 5 to 10 years, is that there is a big difference in the reality of what harm reduction is and a outward policy perception, right, of what it is. Oftentimes for professionals, we run into a difference in opinion on what harm reduction means in the context of community and mental health. And is there a connection between harm reduction and recovery? Is there even a bridge there? And the answer is yes, 100% yes. We've seen harm reduction become a political issue, right? As the scourge of addiction has gotten worse, we've seen harm reduction interventions kind of, in some ways, take the fall for some of the overdose numbers that are happening in this country. We see an ideological way of thinking about drug abuse that's generally more of a moralist approach, that says, no, we shouldn't be doing anything that could in any way or any interpretation be seen as encouraging use or keeping people safe who need to use. No, we should only be looking at discouraging use. A good thing to remember for anybody, and this is for professionals, we get this training all the time, but also people in the community that are trying to help with the scourge of addiction, is this is not about us, right? This is not about our feelings on addiction. This is not about our even sometimes well-meaning intentions to try to help people. This is about them. This is about the people that are going through this process themselves and trying to meet them where they're at, to provide resources to allow them to get to the point where they can engage in recovery. This is certainly an emotional topic because addiction is so intertwined into our society, and we see through our families, through our friends, the negative effects that addiction can have. Our professional duty for the professionals viewing this is to absolutely provide resources without judgment, and to allow individuals to have the autonomy to move forward in their idea of recovery. To the right here of this slide, you'll see a really cool, I like this metaphor, right, of an iceberg. We see above the waterline, we see the things like needle exchange, safe smoking supplies, safe use sites, the things that most oftentimes we're going to think of when we hear harm reduction. We think of safe use sites and legislation, often at the state level and sometimes the federal level, over the legality of safe use sites, the legality of needle exchanges. What does it do to hand out free smoking supplies to people? Does that help? Does that hurt? So that's often the discussion that's happening regarding harm reduction, right? Now, below the waterline, we're going to see 95% of what harm reduction interventions are, especially at the community mental health level. Things like test strips, things like drug checking kits to make sure that the drugs that individuals are using are what they think they are, overdose education, STD screening, access and equitable access to safe housing, reproductive health educational supplies, public health programs, day centers, social spaces, non-punitive care and diversion programs. Very key, very important. Informed healthcare providers, right? So having people who are providing this healthcare, be it a primary care physician, a dentist, a therapist, having them informed on what harm reduction is and how some of these interventions can help. Mobile medication assisted treatment. So being able to offer these services in rural areas, also super important. Having providers with lived experience, perhaps the most important element. Expanded telehealth, lower barrier services. So trying to meet people where they're at, not have these, hey, you got to be here at 1 p.m. And if a client doesn't show up, they get cut off from services. No. Let's try to make services as easy to access as possible so that we connect with that person who might be struggling even to make that first appointment. And by offering the lowest barrier to doing so, we're really giving them the best chance to get their foot in the door towards recovery. Also, living wages for harm reduction providers, right? So how do we make this field a place where people can work in and also live their lives and be able to afford the things that they need to do to live successfully so that they can come in every day and provide these services to the most vulnerable people in our society. So all super important questions that we will continue to discuss. So why harm reduction? Why now? Why are we making this a focal point of recovery? So this is an innovative strategy responding to decades of failure. In 2021, there were 106,000 deaths due to overdose in the United States. That's a vast increase, even in the last 5 years, especially so in the last 20 years. The reasons for that are many, but the most obvious reason is the proliferation of fentanyl. Fentanyl is an extremely easy drug to overdose and die on. And like we like to think of, if you aren't alive, you can't recover, right? So keeping an individual alive is essentially the most key component to helping them towards recovery. Because if they use fentanyl and they pass away, that's another person that we've lost. That's another opportunity for recovery down the road that has been extinguished. The national public policy has not worked. 100% has not worked. How do we take that knowledge that we've been doing something that maybe hasn't been effective, a punitive approach that hasn't been effective, and how do we craft that into policies that can help people right now? Health inequity, prison pipeline, drug war fallout, all super important, bigger picture elements of the addiction crisis in this country, and elements that harm reduction can address and try to improve. This is a public health approach. So not only does it require engagement on a community mental health level, but as you saw from the previous slide, a lot of these harm reduction interventions are focused on public health. How do we get buy-in from the public health sector? How do we get buy-in from private hospital systems? These are all super important questions. This is a disease model, and we look at this as a disease which we are trying to treat with every single tool that we have, every single tool at our disposal. And it's a public health crisis that needs not only addressing from the community mental health and psychological side, but the public health side, the housing side, the social side, the family side. Every single element of society needs to be motivated to make this change. Peer-led. You've heard me mention this a couple of times because the peer-led nature of harm reduction interventions are the most important element of harm reduction. Guided by people who use drugs and people with lived experience. A non-punitive approach, an autonomous blueprint to recovery. And I love that phrase, and I love that that theory and that philosophy, right? We are using these interventions to provide individuals with this blueprint. It's not a blueprint that we're making, right? That doesn't work. It doesn't work. What does work is giving people tools to create their own blueprint towards their definition of recovery. And if I didn't believe as a professional that harm reduction interventions led to recovery, I wouldn't do it. The reason that we're adopting these strategies and the reason that we're pushing for these interventions to be used in a public health sphere is that we believe as professionals that they lead to recovery. People in recovery, peers, people who use drugs believe that these interventions lead to recovery. And that's a really important distinction, especially with the conversation happening at the national level about whether or not these interventions work. We believe they do, the data says they do, and we're here to help implement these interventions into everyday life. Harm reduction and recovery, can they coexist? So a very important point. This is not a clash of ideas. This is not we have recovery on one side and harm reduction where we're encouraging use on the other. Harm reduction connects seamlessly with the values of Jefferson Center and the vast majority of therapeutic interventions that we're doing. Harm reduction is not replacing abstinence, and it's not replacing that traditional recovery path for those who want to take that path and for those who that works for. Individuals who can have additional support to go into AA and who can use 12-step meetings and who can go through a traditional abstinence-focused plan of recovery, 100%, if that works for you, 100%, we want to be able to offer that support and offer those resources. What harm reduction is about is about the other percentage of people that doesn't work for, right? And making sure that we're having all of these tools available to everyone, not just one way of doing things to those who are really seeking that abstinence-only path. Harm reduction practices, again, are a piece of the repair work going on in the mental health field for decades of unfair treatment. A lot of the negative opinions that you'll see in the community as you talk with folks come from misunderstanding. It comes from people being like, well, I don't want a safe use site in my backyard. Okay, that's fine. Let's have the conversation then about what harm reduction principles you do like and what things you do think make sense. We're looking for areas to connect and things that we can agree on rather than focusing on the small sliver of things that we don't agree on. Let's talk about the vast majority of things we do agree on, which is reducing suffering, increasing compassion, and increasing access to resources. Harm reduction interventions are proven to result in higher likelihood to engage in recovery services. Again, keeping people alive, keeping them healthy, reducing the impact on emergency rooms, on the public health sector, are all things that harm reduction can do to help guide that person to the eventual area of recovery that we want them to be at. Autonomy and recovery go hand in hand. And we know for our family members or our friends who are struggling with addiction, very difficult to force someone to make a change that they don't want to, unless you're willing to have them be in a lockdown situation, which is not going to work for the vast majority of people. It's very hard to get people to take that first step if they're not bought in. We've talked about this a little bit, but again, harm reduction is really a core element of it is addressing these health inequities. Harm reduction acknowledges the intended and unintended impacts of past health policies, programs, procedures that have adversely impacted people of color, Indigenous peoples, members of religious minorities, LGBTQI+ individuals, persons with disabilities, persons who live in rural areas, and persons otherwise impacted by persistent poverty or inequality. This is a huge, huge, huge part of harm reduction, and it's a huge part of why we think these interventions make sense. They're going to help individuals who have oftentimes been overlooked. One thing I think is really, really important is this bottom point. So community trust and buy-in has to be earned, right? And that has to begin with truth and reconciliation of community shared traumatic history and the structural racism that perpetuates inequities that we've seen highlighted so often in substance use. We need that community buy-in. This can't just be one section of the community or one agency or one federal arm of government. You need to have the churches involved. You need to have community centers. You need to have work groups involved. You need to have 12-step groups involved. You need to have hospital systems. Every single element needs to engage in these interventions to really have the structural effect that we're looking to have through harm reduction. So a little bit about the framework. Again, I let y'all know that in 2021 was the first time that this language, harm reduction, has been adopted in a federal document with SAMHSA. So the Biden-Harris administration identified harm reduction as a federal drug policy priority. In the 2022 National Drug Control Strategy meeting, harm reduction is described as a public health approach designed to advance policies and programs for people who use drugs and is supported by decades of evidence. What does that evidence show? It shows that we can reduce HIV and Hep C infection We can reduce overdose risk and death. We can enhance general public health and safety and increase by 5 times the likelihood of a person who injects drugs to initiate treatment. Super, super important. Harm reduction has been identified as one of the 4 strategic priorities by the HHS overdose prevention strategy pillars. Those go along with prevention, evidence-based treatment, and recovery support, along with harm reduction. First ever federal document to outline harm reduction, so let's celebrate that. I think, when we look at this, oftentimes there's a ton of negative as we look at the history of harm reduction and trying to get these interventions to the people that need them. Let's take a moment to celebrate and acknowledge that this is a huge step forward, that we're going to see increased funding. We're going to see increased resources for these programs. And that's something to celebrate. Okay, so I'm going to talk briefly about the 6 pillars of harm reduction. So these pillars have been created to drive conversation and establish initial points of reference for harm reduction providers. They connect with the 12 principles and 6 core practice areas. Mainly for our discussion today, I'm going to be talking about these pillars because these are the main ideas. This reframes harm reduction as a wide breadth of services with roots in motivational interviewing, unconditional positive regard, and interventions applicable in a wide variety of clinical settings. I'm using some clinical terms here, so I'll just give a brief explanation. When we think of motivational interviewing, the best way to think of that is a therapeutic engagement that is client-led and autonomous for the client and meets the client where they're at, helps the client establish their own goals. It's a good way of thinking big picture. What does motivational interviewing mean? Unconditional positive regard, another clinical term, but basically the short of it is this means treating each person as a human, giving them the respect that they deserve as a human being, just as you would every other single person, and allowing them to experience mistakes, failures, and not having that alter your perception of them as a human being. These pillars can be practiced within organizations that do not primarily provide harm reduction services. So, for example, this could be a case manager at Jefferson Center, at a community mental health center. This could be someone with the Denver Health Harm Reduction team who's applying specific harm reduction interventions. This could also be someone, as I said, even in a place like a dentist's office, being trained in some of these interventions so that they can help identify and point people to resources who might come in with IV drug use or another piece of drug use. They could be interventions that are used in the court system, in the criminal justice system, in the hospital system. Any single area of life that we're interacting with people who use drugs, which, as we know, is probably every single area of life, we're going to be able to provide these interventions. So it's a wide breadth of services and a wide breadth of ideas. These pillars can not only help engage with the individual, but they can help engage with that individual's family. So how do we help connect the family to services and help them feel supported in this journey also? So the first pillar, as we discussed, the lived experience, the guided process. All aspects of harm reduction interventions are guided from this core principle of lived experience and peer work. It should include a formal mechanism or role to meaningfully include voices of people who use drugs. So this is an important distinction. Not only people who use recovery, but we are really going to people who are currently involved in this crisis, getting input from them, getting ideas from them, allowing them to have an active role in how we are presenting solutions to this population. And this is, like I said, this is a radical way of looking at this. We want to get every voice heard, I think is the best way to think of this. And the people that are currently experiencing these problems and are having everyday, daily IV drug use, of course, we want to hear from them. Of course, we want to know what works for them, what doesn't work for them. Their voice is super, super important. Pillar 2 embraces the inherent value of people. All individuals have inherent value and are treated with dignity, respect, and positive regard. I think this pillar especially connects to the stigma, right? The stigma of drug use and how drug users in our society are often looked at as lesser than. And they're people who are on the bottom rung of society and who don't have access to the same resources that other people do. And treating individuals with respect, embracing their value of every single person is key to these interventions working. You can't, one doesn't go without the other. You can't have a hospital admin person screening for IV drug users without this way of looking at them. You can't have them looking down. It's not going to work. Never patronize or pathologize people who use drugs nor their communities. Not helpful, and not something that goes forward with the ideals of harm reduction. Acknowledgement, just a general acknowledgement as a society of the realities of substance abuse and the nuanced and complex reasons for use. This is not a one-size-fits-all problem, and the solution is going to be applying to everyone also. It's a very nuanced problem, and we need to acknowledge and recognize that. Pillar 3, community engagement. I alluded to this a little bit earlier, but we've got to engage with communities, especially those that have been impacted by systemic harms. Funding agencies and programs that sustain cultural practices and value community wisdom. So getting input, getting buy-in from different community organizations, be it a community mental health organization, a church group, a community group, very, very integral, very important. Community-led initiatives with geographically specific, culturally based models. So, we know that one approach that works in Philadelphia, Pennsylvania, might not work in rural Colorado, and likewise, and that's okay. We're looking at a different cultural perspective. We're looking at different demographics, and acknowledging that is important. And we're looking at a different drug, right? So sometimes certain drugs and certain ways of using are prevalent in certain places, not prevalent in others. And going about this process with thinking geographically specific interventions is super important. Each community is given autonomy to improve their environment. Again, this is a macro idea, but it's also micro in that we are doing this with each client. We're also doing this with each community. Each community is given the autonomy to improve their environment. We are not coming down with a heavy hand of this is how it has to be. There's an open willingness to have a conversation about what works and what doesn't, while also respecting the community at large. Pillar 4, equity and social justice. So all aspects of work incorporate an awareness of race, class, language, sexual orientation, and gender-based power differentials. Pro-health and pro-social practices align with the organization and mobilization of direct services, and the acknowledgement of past harm and discrepancy in services of minority groups. Again, the idea, the element that I would emphasize here most is coming with an open ear, right? Not talking for a little bit, just listening. Can be the first step and the most important step into making this pillar a reality, especially when we're working with communities that have experienced systemic racism. Listen first. So pillar 5, very important from the perspective of community mental health, which is an important part of this venture, but really any intervention. Lowest barrier access, non-coercive support. Lowest possible requirements for access. So an example of this might be not requiring someone to come in person for 2 hours, complete paperwork, and go through a very regimented administrative process to get involved in a program. What can we do to make this easier? Can we offer a telehealth appointment? Can we offer digital signatures on legal documents? What can we do to make the process easier? For example, at Jefferson Center, a recovery clinic has a no appointment process. So you don't make an appointment. You come when you can come. You have a bus ticket. You have someone to watch your child. You're able to come at 10 o'clock on Wednesday. We're open. That's an example, but an important example of how we can lower barriers to increase access. Non-punitive and non-judgmental. We are not punishing. We are not judging. We are not demanding abstinence or sobriety to walk through that door to engage in services. We are here to create an autonomous blueprint, as we discussed, for recovery, with the client at the head of this process as the expert. The client is the expert. Participation in services is always voluntary, confidential, and self-directed, free from threats, force, and the concept of compliance. We certainly do work with individuals who are mandated through the courts, and that's okay. We just don't want to make that a requirement, right? We don't want to make it a requirement that you are committing to a certain set of standards from day one. We want this process to be voluntary, obviously confidential, and self-directed. Data collection of any kind requires informed consent. Super important for any time you're working with individuals, especially from communities that have experienced poor treatment in the past. Any data collection, there needs to be an element of informed consent. Pillar 6. So positive change as defined by the person, driven by a person-centered positive change in the individual's quality of life. I'm not going to tell an individual seeking substance use treatment what they need to do to improve their life. I want them to trust me enough to tell me what that's going to look like for them. And then for me and my team to come in and provide the resources to help them get there. Positive change can be defined by moving towards more connectedness to the community, family, in a more healthful state as the individual defines it. Individual defines it. Very, very important. If the individual defines success as only using their drug of choice once a week, 100%, we're on board for that. We're on board for that. Why? Because it's reducing the hold that the substance has on the person. It's making it more likely that they're going to come back and engage with us. It makes it more likely that they're going to feel like a success, right? That they're not going to feel like complete abstinence is a requirement a week or 2 weeks coming into recovery, because it's not. So very, very important that the positive change is defined by the individual, not the organization. Many pathways to wellness, including full abstinence and non-abstinence. This isn't a way of looking at recovery that says abstinence is not okay. For a lot of the individuals we work with, full abstinence from substances and alcohol is going to be necessary for them to reach recovery and get to where they want to be. Not for everybody, and that's okay. And that difference is okay, which is an important part of the messaging that we're trying to bring, is that full abstinence works for some, it doesn't work for others. And a lot of people who come to a program without a requirement of abstinence later get there, right? They later see the benefits that reducing has in their lifestyle, and they say, actually, maybe I don't need to drink on the weekends. Maybe I can make further reductions and get to an abstinent lifestyle if that's what I want to do as they go through this process. Super important. Some of the supporting principles, I'm not going to go through all of them, but they reinforce the pillars and provide more structure and guidance to the framework. All of these resources after the webinar will be made available, so you'll be able to access these in the future. I'm just going to click through these quickly. Again, we're not going to talk about them today, but these connect to the pillars and create a more direct intervention to what harm reduction means. Core practice areas, again, I'm not going to dive deeply into those today, but again, the practice areas are the real life interventions. How do we take these ideas and put them into society in a way that they work? The core practice areas are going to be how we do that. Awareness of resources is key. This is the meat of the framework, right? These are the interventions and the roles that are actually going to be doing these things. So again, I'll provide this information after the webinar that you'll be able to get access to. I'm going to talk about specific programs, specific resources in your community that you can access for harm reduction resources. Okay, so that comes to the end of the webinar today. I know it's a lot of information and there's a lot of history here. There's a lot of work that we in community mental health and we in therapy and drug treatment, we need to work on. But again, it's a multidisciplinary approach. These interventions can work in every single area of society. This way of looking at drug use, of looking at people who use drugs with a compassionate lens, is the most important thing you can do if you want to help this population. Does not dissuade abstinence, get that out of the way right now, is not solely focused on things like safe use sites and needle exchange. Those are an element of harm reduction practice. They are not by any means the majority of the interventions that we're talking about. Client-directed definition of sobriety, very important. Use this as a guidebook for implementing harm reduction interventions, can be combined with 12-step programs and other traditional recovery strategies. This is a full tool belt of interventions, and multiple approaches are always necessary to address a problem which is really complex. Every person in addiction is different, and every recovery is going to be different. So keep that in mind as you're approaching this problem and thinking about ways that you can make a positive impact. I do have a list here of resources that were brought in for this presentation. Also, just really great articles to read and things to read up on as you're furthering your understanding of this really complex topic. I especially encourage everyone to take a look at the SAMHSA Harm Reduction Framework in full, which is linked here and will be linked after the webinar. So thank you again very much for joining me today, and I hope it is a journey and a continuation of understanding of these principles as we continue as a community to work together to try to improve this problem and help others in our community. Thank you so much.